Hey, my name is Jessica Anderson, and I'm doing my hot topic on failure to thrive. So what is failure to thrive? Failure to thrive, or FTT, is not an actual disease, but a broad term that describes a symptom of a lack of weight gain that is proportional to standardized growth charts. This can be a symptom in all ages, from infant to elderly. Three major causes of FTT are inadequate caloric intake, inadequate caloric absorption, and excessive caloric expenditure. So what criteria meets the definition of FTT? It is a weight less than 80% of median weight for length less than 80% of ideal weight for length less than 10th percentile, the body mass index, or BMI, for chronologic age less than 5th percentile, or it's a weight deceleration crossing more than two major percentile lines on age and population appropriate growth charts. What is the importance of growth charts? Well, the growth charts are used to compare your child's height, weight, and head size against children of the same age. Growth charts can help both you and your healthcare provider follow your child as they grow, and these charts may provide an early warning that your child has a medical problem. Growth charts were developed from information gained by measuring and weighing thousands of children. From these numbers, the national average weight and height for each age and gender were established. The lines or curves on growth charts gives the provider and parent an idea how their child compares to others at the same stage and age. For example, the weight on the 50th percentile line means that 1/2 of the children in the United States weigh more than that number, and 1/2 of the children weigh less. So what do the growth charts measure? At each well child visit, your provider will measure the following: weight, which is usually measured in ounces, pounds, grams, or kilograms; height, this is usually measured while lying down if a child is under age 3, or standing up if they're over age 3; the head circumference of the infant. Each of the child's measurements is placed on the growth chart. These measurements are then compared with the standard or normal range for children of the same gender and age. They will be able to continue to use that growth chart as your child grows. Here are some examples of growth charts for both male and female that are showing measurements that are below the 5th percentile and therefore indicative of failure to thrive. So let's take a look at the pathophysiology of FTT. The pathophysiology can depend on etiology and be classified as organic or inorganic factors. But basically, in a nutshell, it's a lack of necessary calories for adequate growth. This kind of goes back to our three most common causes of FTT, which included the inadequate caloric intake, inadequate caloric absorption, and excessive caloric expenditure. Some of the associated conditions that may cause inadequate caloric intake include poor food intake, chronic illness, inappropriate type of feeding, anorexia and bulimia, and these are often seen in the adolescent and teenage group. Socioeconomic conditions such as poverty and neglect. Inadequate caloric absorption. Some of the associated conditions that may cause inadequate absorption are GI issues. A lot of times you have chronic vomiting, chronic reflux, irritable bowel disease, celiac disease, those with chronic renal disease. Cystic fibrosis is a big one, and metabolic disorders. Next, we're looking at excessive caloric expenditure. Some of the associated conditions with this include hyperthyroidism, chronic renal disease, chronic heart disease, endocrine disease, and a lot of the malignancies. So let's break these down by systems in which we can kind of look at the risk factors involved with them as well. We're looking at the GI, which includes things like Crohn's disease, GERD, pyloric stenosis, cleft palate and lip, Hirschsprung's disease, IBD, and malabsorption. I like to pay extra attention to GERD, pyloric stenosis, and Hirschsprung's because these are issues I have seen personally that contribute to FTT. GERD is a big problem in infants, and I really like the image of a newborn stomach capacity. All too many times you have moms feeding a 3-day-old the volume that a 1-month-old should be getting, and they just don't really understand why the third newborn continues to vomit after feeds. So I think that's a real important visual for those moms to see that their little stomachs are very, very small. We also see a lot of times the pyloric stenosis. We have those moms that come in that just say after feeds that their baby is projectile vomiting everywhere. So these are a few of the conditions, as well as Hirschsprung's, that we see frequently and can contribute to FTT. Some more systems we can look at, with risk factors are heart or lung problems. Those can affect how oxygen and nutrients move through the body. Cardiac disease leading to congestive heart failure, pulmonary, such as asthma, cystic fibrosis, abnormalities of the upper airway, and recurrent infected tonsils and adenoids. If you look kind of here, patients with CF tend to have increased mucus production, especially in the pancreas, which can result in poor food and nutrient absorption. So cystic fibrosis, pulmonary and GI issues with that. Other risk factors include the endocrine and metabolic systems, neurologic, psychosocial, infectious, hematology, environmental, prenatal care. If you look at the endocrine, we can see that hypothyroidism, pituitary disorders, adrenal insufficiency, growth hormone deficiency. Neurologic, our kids with CP. We can't rule out psychosocial, depression, anxiety, anorexia, bulimia, and abuse. Infectious disease, environmental issues such as lead exposure, and also got to look at the prenatal care that the child had received. Are they small for gestational age? Were there any perinatal infections? So what's our prevalence rates and complications? So 5 to 10% occur in the United States. Children living in poverty constitute higher rates, and children living in underdeveloped countries also yield higher rates. Complications, FTT can result in long-term issues that include social and emotional health, such as short stature, lower cognitive functioning, which leads to poor academic functioning, increased risk for adult disease. So what is the psychosocial impact? We got to ask ourselves, is the FTT due to an organic or inorganic factor? A child that has failure to thrive due to neglect or starvation will have a different psychosocial impact compared to a chronic or congenital defect. Children with non-organic failure to thrive can often have issues with personal interactions and may prefer distant social interactions and relate more to inanimate objects. A child that has a failure to thrive due to an organic reasoning, such as malabsorption issues or chronic illness, will prefer touching and holding and personal interactions. Family members that are caring for a child with organic etiology spend much of their time away from home and other family members where their child receives care, and this can be a stressful time emotionally, psychologically, and financially. So what is the treatment for failure to thrive? It is really completed by using an interdisciplinary team. We need pediatricians, nutrition specialists, physical therapy, speech therapy. Those are just a few of the many resources that it may take. It is important that causes that are treatable are managed, such as poverty or neglect. We need to treat those underlying chronic conditions and provide education to family members. The biggest form of treatment is to provide nutritional rehabilitation. This can be by mouth, NG tube, G tubes, or TPN, depending on the severity and history of the patient. I have listed some support groups here that y'all can follow the link to, and this is things online that will help with failure to thrive and give parents some support. Here's the references, and that is the end of my presentation. Thank you.